for today, Tuesday, April 27th. And this is part of the Alzheimer's and related dementias task force. So the first thing we need to do is go over our attendance for who is here. And I'm going to just look at our participant list. I don't know if that's probably the best way to do it, but how about this? So we have Leanne Smith. We have
Present.
Joe Russell.
I'm here.
We have Pete Van Runkle. Am I pronouncing your last name correctly?
Van Runkle it is.
Okay. We have Sally Boland. I know we have representing from ODA. Is it Sarah Duffy and Alex Lapso? And then I see we have, okay, there is someone on here that is absolutely blank. So I'm not sure who exactly that is. And then there's Tom Simmons. Tom. Hello?
Yes, I'm here.
Okay.
Representative, and to everyone's benefit, Tom Simmons is our policy manager for the department. So we thought, based on the conversation we had last week with regard to rule, among other policies, whatever the case may be, with regard to state law, with Tom being our rules manager and policy manager, thought it would be appropriate for Tom to join us today. If there were any more direct questions specific to policies or any guidance offered by the state to address dementia, those living with dementia, as well as their caregivers, we might have another representative from ODA joining us today. I don't know if her schedule allows, but if not, we can certainly attempt to see if she can join our next meeting so that we can continue this conversation.
Okay, that sounds good. Thank you so much for that clarification. And I don't know if that's with the screen share, but okay. All right. I know I had issues with accessing the share file, and so Pete was so gracious to send out a copy of the meeting minutes. And for those who have not reviewed it, can you take a moment, excuse me, can you take a moment to review the meeting minutes, and see if there were any additions, corrections, or anything of the like?
Representative House, may I just go back for roll call because I'm taking minutes today? And
Yes.
I think there's another person on the line. Like on my screen, it just says the letter B, like as a boy. And I just, for roll call purposes, I just wondered, is that just an extra? I know sometimes people call in with an extra phone. I don't know, Alex, if you can see that, or if you can
I see a
Representative.
blank. That's what I was saying. On my end, I just see a blank, but
Yeah.
I'm thinking, I don't know. I'm gonna ask Sarah. Sarah, do you know, was that something maybe with the recording that you know of? Or
I
not?
have an interloper.
I am not a host, so if Alex, maybe can you clarify? You know, this is definitely open in public, but just wanted to recognize who that is. Do you know?
Interestingly, I don't see anyone under the participants list that meets any of the descriptions referenced. So,
Okay, so
the joys of technology.
we are just gonna go with it. So yeah, we'll just put it as an asterisk mark, Sally, and then we're just gonna keep moving. Is that okay?
That's great. Thank you so much.
Sally, can you please add Harvey the rabbit to the attendance list today? Thank you.
I will. I think he's from my area.
And sorry, I was on mute. If, as far as I can see, everyone that you can see on your screen is everyone in the list. So And I don't actually count as a participant, so you can put me, but I'm not on the committee.
Right. Just wanted to say who was present.
That's fine.
Thank you. Okay, going back to the meeting minutes from our meeting last week, April 20th. Again, thanks, Pete, for completing our meeting minutes. Did everyone have a chance to review it? Are there any additions, subtractions, or discussion? All right, well, could there be a motion to accept the meeting minutes from last Tuesday, April 20th?
I'll make a motion to accept the minutes.
Is there a second? So moved.
I can second that. It's Leanne Smith.
Thank you, Leanne. Okay, all those in favor of accepting the meeting minutes, say aye. Wave your hands, do a thumbs up. We'll do it. Thank you. Are there any nays? All right, the ayes have it. Okay. So what we're going to do, and I'm going to just go over, once I get access to the share file, we'll be able to put the meeting agenda, but I believe it was Sally who did the agenda for last week as she facilitated, and I just updated that one. And to go over that very quickly, for the purposes of our committee, what I did was just take it. So it's just an introduction, going over meeting minutes, going over our homework assignment, which was from last week, setting the time, the note taker and facilitator for the next meeting, and then an adjournment, just kind of our following kind of procedure is what I follow for the agenda. And so that's kind of what we're laying out today. And so as we got into the work last week, last week's assignment was a pretty lofty goal. And we had the conversation of just really working to be a bit more realistic, just seeing that the substance of the conversation tends to be, pretty robust. And so with that, it seems like we will begin to pick up on point number 6. And with point number 6, give me one moment. Go to my other file. Give me one moment. No.
While everyone is getting situated, Amelia Jackson has joined us. She is one of the dementia experts with the Department of Aging within our Elder Connections Division. And so in addition to Tom, Amelia can certainly be a great reference and of help to this committee as we proceed with some of these questions and address some of these points. So Amelia, thanks so much for joining us. Really appreciate it.
Yeah, sure. Thank you for having me. I see some familiar faces already on this committee, so I'm in good company.
And just I would say a follow-up question, Alex, is the idea, I guess I would say for the purposes of this our capacity committee, would it be helpful, because again, I'm not as familiar with Tom and Amelia, maybe others are, and so maybe facilitating the conversation, if we have questions, or Tom and Amelia, if you have if you know something that could add to this conversation, if it would be helpful, you could just chime on in. Would that be okay with you all?
Yeah, that's fine.
Absolutely.
All right, great. So I have point number 6, where we left off, starting off with the dementia-specific training requirements for employees of long-term care facilities. And so with that, who would like to begin or start where we left off when we cut off? And I'm going to be one of those people because I know we are also eager beavers to talk. I can just go around, do a little round robin to see if anyone has anything to chime into. So just going by the list that I said, Leanne, do you have any thoughts on some of the training requirements? Okay. Joe, any thoughts?
My initial thought is to have some standard set of education requirements. I think that may be obvious, but I think, this is actually a subject that there's been some legislation recently that's been introduced to kind of address this. So I think having some standard set of education requirements that there's an ability for multitude of different education opportunities, either through different organizations to provide that. So there's not just one source that people can go to for that. And also making sure that it's flexible enough that it can change over time. Just like so many other things, we don't want to chisel it in stone and say, this is the way it's got to be forever, but be able to say, okay, here's where we're going to start and maybe grow from there. And I think that it's worth probably having a conversation over the level of requirement for that training. That is to say, that is the training going to be a hard requirement for you to serve this population, or is it going to be maybe a hard requirement for you to say that you specialize in serving this population? I think those are some of my initial thoughts. But in terms of, how many hours someone should have for this subject or that subject, I'm not really that big of an expert to be able to give that level of input. But those were my initial thoughts.
Thank you so much for that, Joe. And then Leanne, I do see that you have your hand raised and maybe you called in. Is that number you? You were having some technical difficulties?
No, actually, I'm on. I've been on the call. I just realized I was talking to you with the microphone muted. So I apologize for that.
No problem.
So my initial thought is I feel like it's crucial. It is a crucial piece of for those who are going to be working in specialized care units for those with dementia and Alzheimer's. I feel, again, personal experience with my mom, I feel like it's a very crucial piece of the care. So how that looks, how that rolls out, I agree with the previous comments that there needs to be, some type of structure for that. But I feel there should be actual hands-on training, actual day-to-day working with the actual people that are dealing with these, these diseases and this dementia, because it's one thing to go through an in-service or have a meeting, but I think until you're, kind of living their day with them, that training is crucial. So I feel there needs to be an extensive training program. And along with that, pay that's commensurate with that, if they're getting this specialized training and, that's something they can carry through them. And then maybe it's kind of a, they train other people coming on. So those are kind of my initial thoughts.
This is Jean Thompson. My apologies. I'm having technical difficulties this morning. But in any event, I feel that one thing you said, Leanne, is absolutely true. I think the best training is mentoring, actually on the job with someone. I will say and I apologize because with my difficulties I entered late, but I do think that we need to be cognizant that all long-term care right now is facing a huge workforce challenge. And so I think we have to be cognizant. In fact, yesterday on the full committee meeting, I believe Director McElroy said realistic and funding expectations. I mean, there can be aspirational goals, but then we also need to establish realistic goals at the same time. But I do agree with the comment that the best training is really mentoring and working with someone, following them through their day.
Thank you for that. Next, I see Pete. You have the floor. Pete, are you on mute, maybe?
I'm sorry. I took my hand down, but I didn't unmute. Thank you, Representative. And I just want to admit that I fell down on it because we were supposed to enter stuff into the share drive and I did not. It looks like there is some stuff, but I don't see anything on this particular topic on our homework. But anyway, I think where we started out before was in our very closing discussion at the end last week was to put down or enter into the share drive what the existing requirements are, because there are existing requirements for skilled nursing, for assisted living. I think there are some for home health as well. So at least that way we have the baseline of what it is, and then we can talk about, okay, do there need to be changes or additions to that? But I think you got to have the baseline before you can go on.
So okay, Jean, I hear you were going to talk. Go ahead.
Well, I was just going to say I did enter in the share file the residential care facility or assisted living current requirements for training. I did put that in. It's in my notes that I put in, not this week, but because this was one of our original numbers, it's in the my original comments on number 6. Because I'm assuming
I was looking at I was looking at the capacity committee homework as of April 26th, which I thought was our working document. Maybe I'm wrong about that.
I don't know, Pete. I'm a little confused on that, where we enter these things. I just put it in under the capacity committee as my homework, but it's from the first week because we didn't get through everything at our last meeting from the first week of homework. But I did enter in the current assisted living training requirements. So, but I like your thoughts. I agree. We need to start with what's there right now.
So can I ask, for the purposes of, like me, I'm not looking at the shared drive, and because this is kind of streamlined, would somebody be willing to just briefly, Jean, since you did put it on there, would it be possible, or Pete can just talk briefly about what the baseline is?
Well, I could talk about it for assisted living. I honestly don't know about it for skilled care, so I would look to Pete for that. Currently, and it's been a rule for quite a while, that RCFs have to train all staff serving cognitively impaired individuals. There's also a separate training for anyone with mental illness. Initially, they need 2 hours of training, and then 4 additional hours that year and 4 hours every year thereafter. Rules also require RCF activity program leaders for special care to have specialized training. They also require RCFs, or assisted living as they're commonly called, to provide to anyone and their sponsor moving to a special care unit the facility's policy on care for residents. And the policy has to include mission and philosophy that reflects the special needs of the population, admission criteria, including screening, transfer and discharge criteria, a weekly staff plan for the special care unit, including of how including a statement of how that plan differs from the staffing plan for the non-specialized care unit, the necessary increase in supervision, the description of activities offered, frequency types, a listing of the cost of the services provided by the facility to the resident, specialized staff training and continuing education, the process used for assessment and the provision of services, and the method for altering services based on changes in condition, how the facility addresses behavioral health care needs of the residents, the physical environment and design features that support such residents, the involvement of families and the availability of family support programs, any services or other procedures that are over and above those provided in a non-specialized care unit. So, and that's been there for a while, Representative House. Those aren't new, those aren't really new requirements. But I think that at least, provides an outline of what exists. And that is in the shared drive.
Hey, so two things. Thank you for that, Jean. The second thing is I know all of that was captured in your kind of homework assignment that was originally. So Sally, just FYI, just in case you didn't get everything, because I'm assuming you did not, because it was a lot. Maybe we can just note that as a reference point to be able to have that inclusion into our meeting notes. Leanne, I do see your hand. I was going to circle to Pete and then to Leanne. Does anybody?
I'm sorry. I always forget to take my hand back down. I will do that. I apologize.
No problem. No problem.
Yeah, I, as I said, did not do what Jean did and cut and paste all of the different requirements. The skilled nursing requirements under licensure are similar, and I will make a note to make sure I get that in there before our next meeting. There's also some provisions in the certification rules that are federal. That assisted living does not have, but skilled facilities have to meet those as well. So I'll pull that information out for our next get together. Okay. And I don't know, Joe, if you want to do that for home health, or I can do it. It's up to you. Either way.
Yeah, I'm happy to do it.
Well, thank you. So that will be really helpful. So we can have the baseline, as we indicated, of where we are. Leanne, I know I saw your hand up. You were muted, but I believe you had something that you wanted to add to this conversation?
No, I'm good. I think my initial comments, I think I'm fine. Thank you.
Okay. All right. Sounds good. And so as we are collecting this, so this is, I guess, a question from myself and probably others. So we say we have these initial requirements, and the question I have is, how is it assessed, or how do you hold people accountable to the baseline standard? That's the first question. And then the second question is, how are consumers supposed to know this?
Well, I could address it for assisted living. We're surveyed, and if you see the surveyor from ODH's actual surveyor worksheet, they check on all that training, that it actually happened. Also, that one document I talked about in terms of what an assisted living has to share with a consumer and their sponsor if they're moving to a specialized care unit or transferring to it, that basically they ask to see that document, and which describes all those things that I alluded to, which discusses training, etc. So I think there is some level of accountability on the existing requirements.
Okay, thank you for that. I know we'll have much more to talk about. I know we have about 30 minutes left, and so I know we've had at least a good conversation initially. in regards to point number 6 around the certification, where we need to go. And as we continue in this process, we will have a good baseline for the additional support. And I will say, Tom and Amelia, did you all have anything to chime in? Because I know you all are there, but just wanted to at least see before we move on.
Thank you for asking, but actually, no. I think if any state department had a rule on dementia training and long-term care, it would be the Department of Health. I think they actually already have a rule on it.
I agree with Tom. They're the ones who, kind of regulate and keep track of that. I do want to say I do agree with some of the fellow committee members about, the more specialized training when working with people with dementia. Especially when you talk about workforce capacity, in order to keep those, those nurses or those aides working with that population, we need to give them the tools to do so, such as maybe an online, an in-person, more of a in-person training, not just the mentorship program was mentioned. I leave that up to your expertise, but I do agree with that comment, that we need to give our workforce the tools to do that. Because honestly, I think sometimes that might contribute to some of the turnover issues that we have. We don't give them the tools to care for this special population that needs a little bit more specialized training and care. So,
thank you for those comments. So as we move on to the next point, this is a pointed question. Did we decide to keep 7? I know it was up and down, but are we keeping 7 in here around quality care measures for residential care facilities, or is it not?
I believe we were keeping that one.
Okay, so number 7 is next. So quality care measures for RCFs.
Well, since RCFs
There
are my
aren't any at
area,
this point.
right,
I'm
there are
sorry,
no
Jean.
quality care measures. Oh, that's all right for assisted living as there are for nursing homes. Also, but nursing homes receive a payment, an additional payment based on quality measures, I think. This said, the thing that's very different about assisted living than skilled care is that it is primarily a private pay market. So there is, the state, and quite frankly, in the small assisted living waiver program, I mean, the state is only reimbursing that at, like $72 a day. So I don't know, as we talk about increasing capacity, and as Director McElroy said yesterday, some of these ideas are wonderful and very aspirational, but they have to include funding. I mean, at $72 a day, I don't know, there isn't much room for that, is I guess what I'm saying. And so maybe there would have to be reward payments from the state or something of that nature, as is provided for skilled care. And then, of course, I think you have to also take into account that there's a limit on what people, even in a private pay market, are willing to pay. Not that they wouldn't like more, but there is a limit.
I'd like to flesh out what Jean said just a little bit.
Yeah.
And kind of maybe draw some comparison or contrast really with skilled nursing. As Jean said, skilled nursing is replete with various kinds of quality measures. There's many different ones out there, and in some cases they're tied to funding, either reductions or additions to funding. But a lot of the, not all, but a lot of the measures in skilled nursing are derived from the minimum data set, the MDS assessment that is done on all skilled nursing patients, regardless of pay source. The other source for the quality measures on skilled nursing are from Medicare claims. So again, neither of those things apply to RCFs. RCFs are required are state regulated. They're required by state regulations to do assessments of the residents and to create a care plan for them or service plan for them based on the assessments. But those assessments are not submitted to the state, and we are certainly not suggesting that they should be. To Jean's point, there's just so far you can go with assisted living, given that it is not in large measure a governmentally funded service. But that's really the reason why we don't see a lot of quality measures, really any, other than survey in the assisted living environment. Home health also has measures and submits the OASIS the OASIS assessment federally. They also have, since it's a Medicare funded service, there's also claims submitted. So that's also a contrast with RCS, because RCS is such an organic state, or assisted living is such an organic and state specific service. And the same would be true, frankly, of other kinds of like Medicaid funded in-home care, such as Passport. There's no quality measures there that I'm aware of. Maybe Tom or Amelia can point to some, but I'm not aware of any, because there's not a submission of assessment information for Passport recipients either, not centralized basis.
This is Joe. If I may add and build off of what both Pete and Jean mentioned, I think for at least for home health, the Medicaid rates are less than what they were in 1998, and I think that we have a big concern around asking providers to get an additional credentialing to be able to serve a specific population, whether it be Alzheimer's or a different population, without considering some sort of incentive. I think what would be worthwhile is discussing some sort of structure where there's for this population where there's a rate add-on of some sort. So if a home health agency got the additional required credentialing to serve this population, they would be able to tell the public that, hey, we specialize in this area, and then along with that training and serving those specific patients, that there's some sort of add-on to the rate. I think, to echo Jean's point, I think that's the amount of reimbursement that currently exists for asking providers to do more. There could just like some other things that we kind of look at, we got to be careful that we don't provide a disincentive for providers to serve this population group. So I just wanted to add that piece to it. I think it is a very important consideration.
I agree with Joe's comment.
Well, thank you.
In the last two budgets, we've requested add-on for memory care in the waiver program, and it's never been approved. I just want to put that historical data in there.
And okay, so it is, I'll have a conversation offline regarding that. And I don't know if this would be, or if this is the right setting, or when you have the conversation of ideally, is there, and I guess this kind of goes into the cost of care, which we delved into a bit, but what does it actually cost, or what do you all, for those of you all who are actually living, representing members in this space, I mean, is there a number out there with what, and ideally, the aspirational goal of what people, based on the work and involvement, what it actually costs to perform this level of service? Do you all know? I guess that's a question.
Actually, in my response to item 5 that I shared in the shared file, I listed that assisted living private pay memory care rates for the first quarter of 2021 average, this is from NIC, so it's national, not Ohio specific, averaged $7,065 a month. The current ALW payment is $2,167 plus $750 for room and board paid by the participants. So if you look at the total reimbursement to providers, I guess it's closer to the $2,900 a month, but that's a huge divergence.
Just from a data standpoint, again, I'm kind of echoing myself from the other conversation. This is another challenging area because not all providers, some providers, provider types do, some provider types don't file cost reports. So cost reports, if you're looking at cost versus price, or what people pay or what government pays, I mean, Jean's totally correct that the government pays a whole lot less, and Joe too, a whole lot less than the private market would bear, or even Medicare versus Medicaid. But on the other hand, when we talk about cost, which is a different question, we just don't have the data for some provider types, and that's, I mean, again, it would be an additional regulatory burden to establish that requirement for providers who don't have it, and we don't want that. But on the other hand, it impedes our ability to say, well, the average cost of a day of assisted living, for example, is X. We can say what the average price for that is in the private market, as Jean did, but we can't really say what the cost of providing that service to the provider is. What did it cost them to pay their staff? What did it cost them for the rent or the mortgage on the building? What did it cost them for supplies, food, and all of that? So it's a challenge that we have in terms of lack of data.
Yeah. So the reason.
I agree.
Go ahead.
Well, no, I agree with Pete. Although I would still say I can pretty much unequivocally say it costs more than $72 a day.
Okay. And the reason
we get no argument from me on that point.
So the reason why I'm asking, now putting from a place from a policymaker, it's, we know it's not enough, but it's like, okay, well, where is the point of start? You see what I'm saying? And so it's hard to make a decision when there isn't, if we don't have the information or a place to start. And so hopefully, as we continue in this work for the capacity, we can get to a place where we're at least providing some guidance as to, I'm saying a formula, I don't know if that's the best term, but some way where there can be some more informed decisions on a policy level if you're thinking about increasing rates, what have you. I just think it would be really helpful to be able to provide that type of information so that, again, people could be a bit more confident in adding more, resources or, adding more investment into this area. So.
Yeah, I think with it.
Sorry, go ahead, Joe.
Joe and then Pete.
I think we could certainly come up with some numbers in terms of what it looks like to serve a typical patient per day, but it becomes challenging in the context of this conversation because we don't know what else we're going to be kind of putting into the recipe, right? I mean, we might be asking providers to do more than what they currently do, which could then increase the cost. So that's, I think, the important thing for the discussion at this point is just to have a clear understanding that if we're going to put in quality metrics and then we're going to ask providers to get additional training to do that, that the providers are going to make a calculation as to, can I economically make this work? And if they can't make it work, even if they really want to serve this population, it's going to be very difficult for them to kind of take that extra step. And one of the analogies I like to use is if we're running a restaurant and we're selling pizzas and hamburgers and hot dogs, right? our providers don't necessarily look exclusively at the pizza sales and say, hey, my whole agency, my whole organization's run just off the pizza sales. We also take into consideration the hamburger and hot dog sales. So if for example, if Medicaid is the hamburger, we might be taking a loss on the hamburgers, but we might be making our margins up on the pizza. And so it's that, and using that analogy, it becomes very difficult to then separate those pieces out and make a determination for each individual agency, because at the end of the day, all these organizations do look a little bit different. So just to kind of bring this full circle, I think the important thing is just to understand that what we do in this area is going to have an impact on provider behavior, and we want to make sure that we're not crowding people out of that conversation.
Thank you for that, for Joe. Pete, I know you had some commentary before we're going to move on to point number 8.
I did, and I'll try to make it quick because we do need to move on. But just to your point about, how do we know how do we know what is adequate reimbursement if we don't have cost data? And I think that was summing up what you were asking. And I think another way of looking at it is access. And I'll just use the assisted living waiver as an example of that, but there are other services, that the passport being one, that this same analysis could apply. In Ohio, we have, and this, I'm stealing some of Jean's words, and it's common knowledge, but she says it eloquently. There are way more certified beds for the assisted living waiver than there are people using them. But at the same time, there is also a waiting list for people to get into those beds. And the reason for that is because the reimbursement is so low that providers simply cannot afford to take very many assisted living waiver recipients. As Jean said, it's a $2,000 to $5,000 or more, $7,000 in the case of dementia, difference in reimbursement, and that's not sustainable. So you have to limit down. To Joe's point, you're looking at your various revenue sources, and so that revenue source is a loser. You got to limit it. So that would be a metric for determining whether reimbursement is better. What is their access? Is the waiting list being cleared? Can people who want assisted living services that are paid for by Medicaid get into an assisted living or not? I mean, that's another way of looking at it.
Thank you. Thank you so much for that. Again, some rich conversation happening here. So we're going to shift a bit to point number 8, which is home and community-based services, including respite care for individuals diagnosed with Alzheimer's disease or related dementias and their families. So really trying to see what currently we have out here in home and community-based services, including respite care, and then, if we have time, maybe where we need to go. So let me see, I'm going to look on the list of someone we had not heard from. I know I see Representative Creech is on here, who has joined us. I'm not sure, again, we've been just having a robust conversation, but if you wanted to, just chime in just on this thought, maybe some things that you heard regarding the home and community-based services in this space that you would like to add, and then I'm going to circle to Leanne and possibly Sally. But I know it's hard to take notes, Sally, so we could pass you over to Representative.
Good morning. Sorry I got on late there. I had some difficulties, but no, I'm taking this all in and learning a lot. But at this time, I don't have any input.
All right. Thank you so much. Leanne?
Well, I guess when I look at that topic in our Senate bill that we're covering, are we looking to define how many of those organizations are out there serving this population? I read that, and I feel like there's a ton of probably resources from others that are on this call that obviously offer those services, or are charged with overseeing those types of services. I think they're a very important piece for people as they keep their loved ones home longer. And I feel like that's kind of what people are doing these days, especially this last year. Nobody really wanted to put them in facilities, but I think the home care services and the home-based services are, again, a very important piece of support for people that are not either financially able to put their loved ones in a facility, or they don't want to put them in a facility. So I think if it's looking at more funding for that, or just exactly what this topic is trying to define, I think that's a little bit of my struggle, I guess. I don't know, maybe somebody else has more information on just what we're supposed to be looking at with that.
I guess, go ahead.
Oh, sorry, guys.
Nope,
This is Sally. I think this is one area where I can maybe contribute a little bit, because I work in home and community-based services. And Joe probably has some thoughts too, working in home health. I think a lot of what Joe and Pete and Jean talked about in regards to the reimbursement issues are very similar for home and community-based care. When you look at home health and adult day services, and so I think that's certainly something that probably is going to need to be addressed. I think Leanne is right in regards to, we need to go back and define maybe what this actually constitutes, because it could be very broad. The other thing I think about is, if we think about people, because when we go back to our very first point and talked about early onset and early stage, there are potentially other home and community-based services that are out there that could benefit people throughout the trajectory of the disease. So, and I know that the SAPA went into this a little bit, because like there was one area in the SAPA that talked about preventing cognitive decline, and what are some things that potentially maybe, senior centers could be doing, for people who maybe have mild cognitive impairment, or looking for ways to keep their brains healthy. And I don't know if this is in the context of our task force, but I think there's a lot from a home and community-based sense that could be accomplished. It's just, I think, goes back to the same question as what funding's available, what's realistic. I mean, when I look at, what's available from adult day, I know there's one area, agency region, that has no adult day providers. So, there's just so much from a capacity standpoint that I think we need to take a look at. When you look at early stage and social isolation issues, I mean, COVID's had a huge impact on people in early stage dementia. And, this state of Massachusetts has this whole network that's a whole collaboration of community providers doing memory cafes that are really, really cool. And I think there's some funding that's happening at the state level. So I think we probably, like Leanne said, need to go back and do some definition. I think probably Amelia might have some thoughts about this. There might be some things we could identify, as the director was saying yesterday, through the SAPA. So I'll stop talking.
No, thank you. That was very helpful. So Pete, I see your hand, recognizing Pete, and then I'm going to circle back to Amelia to chime in. Pete, you're up, and if you're on mute, unmute. Thank you.
Darn it. I did the same thing again. To Leanne's question about what this is really getting at, I think it's part of an overall statement, which is looking at defining existing resources, services, and capacity relating to the care of individuals diagnosed with Alzheimer's disease and related dementias, including. And so that's the preamble to home and community based. So I think what this is really looking at is, what is the existing capacity? And we talked about that a little bit last week, and we obviously need to talk about it more, but trying to get sort of an inventory of what's out there which is, easier said than done. Then as far as the questions that start with number 13 are about policies and strategies to address. So that's where we get into things like reimbursement and new initiatives or new ways of delivering services that could be looked at, things like that. So I think this is really an inventory question.
Thank you so much for that, Pete. Amelia, Jean, I see you talking, but can I just get Amelia to jump in real brief?
Absolutely.
And we'll transition to you. Thank you.
Great, thanks. So, the state does have the Alzheimer's respite line item, and that is specifically kind of focused towards those respite services for home and community-based services. And I think most of you are probably familiar with the line item, but, designated is, 50% of the funds, they go to the AAA, and then about 50% of those funds are passed through to the local Alzheimer's chapters, and then the other half of the 50% of the funds stay with the AAA to be contracted out for other services. And the reason for this is because, of course, the Alzheimer's Association has their strengths, and the AAA's, area agencies on aging, have their strengths as well and can offer different types of services, kind of going back to what Sally said, addressing that whole spectrum of care. What one caregiver needs for respite is maybe not the same for another caregiver. And so that's why we partner with them to really address the spectrum of the disease and spectrum of care that caregivers need. So, yeah.
Thank you for that. Jean?
Representative House.
Okay.
Well, first I wanted to just say that.
Hold on one moment, Jean. Jean, can you hold on one moment? Alex?
Absolutely.
Yeah, Representative, if I could actually ask Amelia a question. I'm interested in the word respite itself. How is that defined? Because you mentioned that respite is different for everyone. Every caregiver needs respite in a different way.
Mm-hmm.
And so in what ways do the existing funds through the Alzheimer's and Dementia respite line help define and provide services through quote unquote respite? Thanks for everyone's indulgence.
Yeah, no, so the whole, definition of respite, I feel like we always have this conversation. It's a little bit different defined by everyone. So what we've done is in our policy, with the respite line item through the Department of Aging, we've outlined allowable services that are allowed. And the policy is very broad. So we allow everything from, information and assistance, education, to more of those hands-on respite services, getting someone in there to help with personal care, or maybe even in a temporary institutional stay. You can have a loved one maybe for a week stay in a facility if a caregiver needs that sort of break. I will tell you, looking at the data actually just last week, we did, of course, with COVID, see a very big dip in caregivers utilizing that specific service, of course. But yeah, so I don't have a good definition of, respite other than whatever the caregiver needs to take a break. But it is kind of defined through our allowed services through that policy.
Well, thank you so much for that. Jean, I am going to you. I just want to keep in mind, we have 2 minutes left. So after Jean's comments, we're going to do our wrap up and try to put a little pretty bow. Well, no, it's not going to be a bow. We're going to put a pause. We're putting tape on this present because we have some more bow making to make. So Jean, it's up to you.
Okay. I will go quick. The first, I want to just technically clarify that actually home assisted living under the waiver is a home and community-based service, and just so people are aware of that. I guess that it is tough. I think that in the private pay market, what a lot of families have really enjoyed, but obviously they're paying for it themselves, is a respite of actually, not so much maybe during COVID, but as we move out of that, where your family wants to go on a vacation for a week or 2 weeks, and they want to bring someone to the assisted living community for that period of time. And so I think I agree with all the comments that respite for everyone is very different. We have to work in it work in many fields in it. But I do think, and it's why I asked Director McElroy yesterday and was pleased to hear that actually some of the respite line item could be used actually for, they say, that week stay in assisted living, to give a family that really needed it a real break, because we do have to support this huge unpaid caregiver element in this whole issue. It's a little tricky because technically the Department of Health doesn't recognize respite care in assisted living. If somebody comes for a week, it's like they're coming forever. And from a clinical perspective, I completely understand that, because it doesn't matter if they've been there, you know, if something happens, you need to know everything, whether they're there for a week or they're there indefinitely. But that is a bit of an issue, you know, maybe, but I would like to see ultimately included. I love the idea of senior centers offering something for those initial stages, etc. And but I also like the idea that we would support people who are providing all that unpaid caregiving with an opportunity to take a week or 2 weeks off, because I know in the private pay market, that's something people really like to do. And I like to see those same possibilities exist in the non-private pay market.
Well, thank you for that. So we have definitely had a robust conversations. And I will just say, as from these last two meetings that we've had, it seems like we're on the having conversations like 3 to 4 topics, really probably 3. And so as we look for conversations coming up the next time we will meet, I think our next attention will be on points, I believe 9, 11, and 19. I could be wrong. Am I missing a number in that I have? I have 9, 11, and 19 as our next points. Can someone, am I correct? Have I missed something?
I think that's correct, Representative. I'm just looking here real quick. You said 9, 11, and 19. Yes.
Yes.
Yep. You're
Okay.
absolutely correct.
All
Yeah.
right. Okay. Just wanted to make sure. So with that being said, it seems like right now we've kind of got into this groove of having Tuesdays at 8 a.m. And for the sake of just our time, would it be possible for us to put out there possibly our next meeting on Tuesday? Oh, no, I see we have, I was going to say Tuesday, May 11th, but I see that there's something going on with the Alzheimer's Association. So maybe that won't work. So I would hate to say May 4th, but maybe May 4th or maybe May 18th. What do people think very quickly?
I think we should do the 4th because we've got a lot more ground to cover.
Okay.
I think so too.
All right. So it seems like we are the 1 week group. Okay. So Tuesday, May 4th. Does anybody have any opposition to that? Does it work? Or if not, we're just going to make it work. For Tuesday, May 4th at 8 a.m. will be our next meeting, going over the points discussed 9, 11, and 19. And we will figure out the facilitation between sadly Leanne and myself. We do need someone that will be gracefully be the note taker. Any takers? Any takers? I know it is burning so deep in your soul.
I feel like it's probably my turn.
All right. Woo! You see how that energy works, y'all. One time for Joe coming through with them notes next week.
Yeah.
So good. So we're all set. Again, I want to thank everybody so much for engaging in this conversation. We are making progress. And I know the ODA team will send out again the link for our meeting. Thanks everybody for their time. Are there any final questions, updates, or anything before we end?
I just wanted to ask, is there a better way for me to send my comments, Sally, on all of those items than I've been doing?
You know what?
Oops, I'm sorry. Go ahead, Representative House.
Yeah, so the one thing that I was thinking, as we have these different points, maybe the facilitators, we're going to think of maybe there's a way that we can set it up where people can drop it in under the points. And I think at least moving forward, maybe that's the way we should do it, where we can have each of the thoughts based on the points kind of connected underneath. But again, Jean, maybe that is to be determined, but this is just something I didn't talk to anybody, but I'm just thinking it's a way to maybe organize the information. Sally?
I think that's a great idea, Representative House.
Okay. Sally?
Yeah, I actually thinking the same thing, Representative House. And so I can go in, because I actually put some points in yesterday, but put it in a completely separate document because I wasn't quite sure how we wanted to do that. And I didn't want to insert stuff in Jean's document without I didn't want to be presumptuous. So I can go back if everyone's okay with it, and I'll merge all the documents and put it into one document. So that way everyone can just kind of plug stuff in. Okay.
That would be great.
And then moving forward, Sally, if that document is out there, comments I have, I'll insert in that main document. But I love the idea of organizing it by points.
Yep. I can do that in the next day or two. I'd be happy to do that. So
I think that sounds like a great idea. I think that's kind of what I was trying to talk about last meeting was how do we keep all this organized? The other thing I just wanted to mention really quickly, and maybe this is, with Representative House and Sally, there were a lot of comments that Director McElroy, I think, had talked about our, particular committee yesterday addressing. So I think there's some notes that I took, and maybe we need to talk about that just to make sure that for our next, general task force meeting, we have some of those points in there that she had.
Yes, I was actually, going to mention the exact same thing because I took some notes. So maybe what we can do is kind of compare notes and then come up with something and add it to our agenda next week. Is that okay?
That sounds great. That's exactly what I was saying, because now we are at 9:07, and we want to be very respectful of people's time. We'll put that as the first order of business for the agenda, and then we'll go through the other things. That sounds good with everyone.
Sounds good.
Yes,
and
it'd be great.
Everybody.
And Amelia, thank you for being here. Yeah, no, it's okay. It's nice having the expertise of you here. So.
Oh, Sally, you're the expert if you ask me, but that's very kind of you.
Yes. Yeah. Thank you all so much. Everybody have a wonderful day, and we'll see everyone next Tuesday.
Thank you.
Thank you. Thanks. Take care.
Thank you.
Thank you.